I'm your host, Tom Leary, and our guests today are Roger Baker and Anish Chopra. And before the break, we were talking about the challenges and opportunities in health IT, a conversation that will continue at the 10th Annual Government Health IT Conference and Exhibition June 17th and 18th here in Washington, where professionals from the government, health IT, and the healthcare provider communities will share successes, challenges, and best practices on the use of health IT to empower patients and providers to achieve better health care. This event is free for federal employees. You'll find more information on the Government Health IT Conference and Exhibition website, which is available at govhealthitconference.com. I'd like to move on to some specifics on how health IT is contributing to healthcare transformation, and particularly the potential contributions the health IT is having to clinical and business intelligence, which HIMSS defines as the use and analysis of data captured in the healthcare setting to directly inform decision-making and improve care delivery. In the 19th century, Lord Kelvin was quoted as saying, "If you can't measure it, you can't improve it." Clinical and business intelligence provides insight into what works, what does not work, and how to move the ball forward on improving the healthcare for all Americans. Anish, electronic exchange of health information is certainly a key component of effective data collection. From the perspective of both the public and private sectors, what is the value of gathering standardized quality measured data, and how do you envision clinical and business intelligence being used to support healthcare transformation?
Well, it's extraordinarily valuable. I would begin the conversation by saying, as we shift the payment model to outcomes, what you didn't ask me, and what we naturally will follow in this conversation is, well, what's an outcome? What is the definition of an outcome? I know what a visit is. What's an outcome for improved health? And we've had a bit of a frenetic pace to define outcomes. We've largely defaulted to the idea of quality. And one of the challenges has been, what's the definition of quality? And so if I'm going to get paid to make sure that there's a healthy birth, what is it that I want to convey in that regard for purposes of reimbursement? You know, did I save a young premature baby by providing them care in the neonatal intensive care unit, which really ratcheted up a lot of expense, but I provided great quality? Or was I supposed to have been doing more prenatal care earlier and earlier in the pregnancy that could have helped that pregnant mom retain that child in womb for another few more weeks and have perhaps a safer pregnancy, and one that had a little bit more, maybe more of a traditional cost structure to that delivery? Well, getting to the heart of what quality is, really requires an all hands on deck approach. I'm very proud that we've started the conversation on what quality is. In fact, we made it very clear across lots of domains. Medicare and Medicaid are now starting to pay for quality, and they've defined a certain set of initially, process steps that they felt, good processes would lead to better quality. There's now a conversation about the actual outcomes and the values associated with, is your blood pressure under control, and are you actually able to reduce smoking rates and things of that nature? And so the debate that we're having now is, thankfully, with an all-hands-on-deck approach, private insurers, public insurers, doctors, quality organizations, all sitting around the table, thoughtfully debating what are the right measures of quality. And oftentimes it might be fewer measures, but really impactful ones that are a better way of achieving that productivity goal we spoke of earlier. So point number one is, first, define the outcome. And we're doing that with the debate on quality measures. And then secondly, in any one of those examples, you will find the average institution in America will need to combine information that it has inside the network in combination with information that exists outside of its network. And so the ability to incorporate information across networks is absolutely essential if we're to see the gains that we are hoping in terms of productivity on the quality side. And here I'm very excited about where the Meaningful Use program has come and where we obviously have a lot more work to do.
Right.
Well, first and foremost, we have made it a very clear principle that, at a minimum, every patient in the American healthcare system is entitled to an electronic copy of their own record. So the good news is, with meaningful use rules allowing patients to view, download, and transfer their own data, they're at least in the position, legally speaking, to ensure care coordination. If I take possession of my data and I share it back with my in-network provider, then that allows that in-network provider to calculate, if you will, the quality measure and to make sure that I'm getting all the care that I need if I'm falling short. We also made it very clear with the meaningful use rule in stage 2 that information across providers at a minimum must be able to support a push message. That is to say, if I know that patient X wants my copy of his or her record to be sent to Dr. Y, there should be a safe, secure, and reliable method by which I can push that information. And I'm very proud that the direct protocol has played an important role. An idea, by the way, that wasn't even in existence when we first took office in 2009, was birthed as a collaborative and, in the spirit of lean startup, morphed into pilots that were tested and validated and ultimately made their way into a rule that has applicability across the entire industry. But we now need to evolve to the next phase of interoperability. We have to create the conditions such that, with patient permission and with patient support, that organizations can go pull the necessary records in order to come up with those quality measures when needed. Here's where I think the debate will go, and I look forward to having a conversation with this throughout this, either this or the next chapter of this segment, around whether or not we need to have a new data standard around APIs that would make it easier for organizations to pull information such that they can qualify, or they can produce those quality measures and actually render better care for their patients. And that's a work in progress conversation.
Roger, any observations along that lines?
Well, I mean, I love the ecosystem view of this. We started out as big fans of the nationwide health information network and really implemented down that path. I think what you find is that patient matching is the large issue on those things, making certain that as you exchange healthcare information, you're talking about the same person.
Yeah.
It's pretty vitally important.
Absolutely.
And so there are plenty of challenges that we're going to wrestle down, but Anish makes the main point. You know, we have to have the standards. We have to be able to exchange the information, and when you can exchange the information, when you can build that portfolio on an individual from all the information available on the individual, their health is going to get better, the results are going to get better, the quality measures are going to get better, and it's got to be one of those main focuses at this point.
From a patient data matching perspective, HIMSS is working with the HHS Chief Technology Officer to actually fund an individual to work in their office for as long as 2 years on trying to get the community together around a common approach to patient data matching. So we'll hope to see that before the end of the Obama administration.
Without creating a single ID, which of course we legally can't do.
Exactly. Yeah, so it's an interesting challenge that we're hoping an innovator can jump on board the HIMSS team to take that on with the government.
Great.
So let me turn the focus just a little bit to a different direction here. The Department of Veterans Affairs and, of course, DoD, the Department of Defense, have long been working to integrate their healthcare records to deliver high-quality care to our nation's active duty retirees and veterans. How is Health IT supporting that, and where are we on that road?
Well, so I think at the high level, VA and DoD exchanged the most information about patients of any two health organizations in the country. It's about 5 million patients from DoD electronic records have come over to VA, and there are IT systems between the two departments that, for example, if you have a prescription or a blood test at the DoD, the exact results of that are available in a database that the VA can read as well as the DoD for shared patients. So there's a lot of good exchange of information. And the two organizations have really piloted what it takes to exchange medical information over the years. Good and bad. You know, it isn't all, it hasn't all worked, and to some extent we've learned from the fact that some of that hasn't worked. And rather than get into, where they are these days, I think you can summarize that with the two secretaries are pushing forward on electronic health records and interoperability, and I think the press has covered that very, very well. What I would go to is, let's remember that two things. One is the President's vision for a lifetime electronic record and why that's there. Service members and veterans deserve the best care we can give them, and their full record is important to the ability to do that. Secretary Shinseki often says that the problems that that VA deals with seldom start in the VA. They're battle wounds, they're military sort of things. But the other thing to recognize, it was in 2011, about February of 2011, when the last World War I combat veteran passed. And if you think about how long the VA will be dealing with the impacts of Iraq and Afghanistan with the service members that deserve those benefits, the information about how they were impacted by their service is important to the VA. And also, what happens to them in the private sector is important to the VA and to the service. 50% of the care that VA and DoD provide are provided outside of the VA and DoD facilities. They're done TRICARE in the VA and by private sector doctors that the VA pays for on the VA side of things. All of that information is critical to the care as well, and that information today is not largely coming into the two organizations. So that's important information from an interoperability standpoint. HHS absolutely has to be part of that discussion of how are DoD and VA doing on interoperability. They have to do it to the standards. VA and DoD can drive standards. They have the weight and the dollars to drive standards for the healthcare industry. And we certainly tried to do that down the VELR program as well. So there's a lot of work done, a lot more work to be done. Right. And as you can see, just from what's reported in the press, a lot of dollars going into it. But I think it's very important to keep the much larger scale in mind here. It's not DoD and VA because they're two large and important organizations, but it is everybody who serves the 20 to 30 million people. Now, they're service members and veterans, and all pieces of information needing to come together to provide them with optimal service as they go through the rest of their lives and earn the benefit and get the benefits that they earn by serving their country.
Excellent. So in the 2 minutes we have left in this segment, it seems like maybe we could get into the beginning of a conversation around how you together work to get with others in government on your the Blue Button initiative that has grabbed onto information to support both clinical and business intelligence and quality improvement. Maybe we just touch on that, and then in the third segment, we'll talk about how it's impacting the consumer.
Well, let me just touch on it briefly because Anish does an excellent job of covering this in his book. But Peter Levin, Steve Andra, the folks at Markle Foundation, Todd Park, real drivers of where Blue Button goes. But Blue Button was a very, very simple idea. What if we actually gave people their health data in a very simple format and let them do with it what they want to do with it? And if you fast forward that from a simple idea that we piloted at VA and then started to roll out, I'm trying to remember the number now. I think it's over 100 million consumers can get their medical information downloaded from the various websites of the organizations that serve them today in the Blue Button format. They can combine that data together in any way they want to do. It's their data. They can provide it to their other providers. It's just amazing to me. Innovation takes many, many forms. And sometimes the most impactful innovations are the ones you look at in the beginning and say, that's not going to be very hard. But the concept of, it's your data, you can have it, we're going to give it to you in a form that tools can work with, has blossomed in Blue Button into something that I think in the beginning, I'd say, Anish, we all kind of hoped might be out there. But like somebody who starts a brand new startup company, yeah, I'd love to turn it into Google, but I can't imagine it possibly would happen that way. And that's what's happening with Blue Button.
About 20 seconds left in this segment, so why don't we
Well, here's the interesting point about Blue Button. With all the difficulties to get to the nirvana of the DoD and the VA sharing records, as we speak, there are third-party app developers who can take the Blue Button download from the VA and the Blue Button download from the DoD, merge them, and to provide on a mobile platform a unified view of the patient's record. It'll get better as the quality of the DoD Blue Button download matches the VA. The VA today offers a continuity of care document, which is a fuller medical summary. But the point is, while we're at the larger investment plans to get the two organizations to share directly, we already have very nimble startups that have been proven at HIMSS demonstrating that they can show a unified view of the patient. Not one company, but multiple companies have been able to ingest Blue Button files to the patient. So it's exciting to see the level and pace of innovation, and we'll be carrying that forward in the next segment.
Absolutely. You're listening to Advancing Healthcare Transformation with Health IT, sponsored by HIMSS on Federal News Radio, 1500 AM.